For the series of lecture in cardiovascular disease for the medical student. Our title today, Acute Rheumatic Fever. This is the first lecture in the valvular heart disease and the next two lecture, valvular heart disease and the subacute bacterial endocarditis. The objective definition of etiology, epidemiology, pathogenesis, clinical signs, symptom diagnosis, treatment, and prognosis. Rheumatic fever is a delayed autoimmune, non-suppurative sequelae of upper respiratory tract infection. With the group A streptococci, the disease is characterized by inflammatory lesion involving primary, joint, heart, and subcutaneous tissue. Its pathogenesis remains obscure mainly. The clinical manifestation include polyarthritis, carditis, subcutaneous nodule, erythema marginatum, and chorea as a major representation in a varying combination. Acute rheumatic fever is a systemic disease of a childhood, often recurrent, that follow Lansfield group A beta hemolytic strips. It is a delayed non-suppurative sequelae to the upper respiratory tract infection with group A. It is a diffuse inflammatory disease of connective tissue, primarily involving heart, vessels, blood vessels, joints, subcutaneous tissue, and CNS. Epidemiologically, age involved is the 5 to 15 years, and the most susceptible group age group. Rare below 3 years, and even rare below 35 years. Girls are more than boys in Korea are rheumatic heart disease, while girls and boys in acute rheumatic fever in general are equally common in the third world countries because of environmental factors, overcrowding, poor sanitation, poverty, poor access to the medical care. Incidence is more during season, fall, winters, and early spring. The incidence of acute rheumatic decline in developed countries because of improved social condition, more hygiene, less crowded living condition, better nutrition, improved access to medical care, to lesser extent, this reduction to the antibiotic and virulence of the organism. 3 to 6% of population is susceptible to acute rheumatic fever. WHO incidence say is the 500,000 acute rheumatic fever a year. 97% in the developing countries, more than 50 per 100,000 children per year. Really, this underestimated. Some figures said it's 80 to 1 to the 500, while in developed countries the number is very low, it's the 10 per 100,000 population. So it is pathogenesis mainly unclear, but say a delayed immune response to infection with a group A beta strep after a latent period of 1 to 3 weeks, with some exception. We will discuss it later. Antibodies induce immunological damage occur to heart valve, joints, subcutaneous tissue, and basal ganglia. The recurrence incubation period, as we said, is shorter in keeping the faster immune response, not classical that 1 to 3 weeks, maybe shorter. So the group A beta hemolytic strep strain that produce rheumatic fever have MITG, what's called rheumatogenic, type 1, 3, 5, 6, 12, and 24, even 12. Pharyngitis produced by group A strips can lead to, tonsillopharyngitis can cause acute rheumatic fever, rheumatic heart disease, and post-streptococcal glomerulonephritis, while skin infection and vertigo, like produced by group A, lead to post-streptococcal glomerulonephritis, but not acute rheumatic fever. Only nephrogenic strain 49. With impetigo, it will not result in the rheumatic fever or carditis because as most probably is a skin lipid cholesterol inhibit antigenicity of this organism. This group A streptococcal tonsilopharyngitis lead to the sequelae of arthritis, carditis, in the skin disease and the neurological disease. There are certain criteria of these. Group A to produce acute rheumatic fever. Firstly, pharyngeal infection with a group A strep, certain rheumatogenic strain of a group A with the M protein, throat infection of sufficient duration, and persistent throat infection may or may not be symptomatic. We will find clinically some cases rheumatic heart disease, but not have history of acute rheumatic fever, really at that time is asymptomatic. Throat infection is must not with the bioderma skin infection. Infection of a sufficient throat infection, really not with the skin infection. Skin infection. Infection of a sufficient duration to produce antibody. Brisk and sufficient antibody response to infection and genetic predisposition too. A lesion, really fibrinoid degeneration of connective tissue, inflammatory edema, inflammatory cell infiltration and proliferation of a specific cell, resulting in the formation of Aschoff nodules that cause pancreatitis, arthritis, nodule, and the basal ganglial disease. And we will discuss a major criteria. Arthritis really is the most common clinical feature. Fleeting migratory polyarthritis involving major joint, commonly involved joint, knee, ankle, elbow, wrist. We said arthritis, hot, tender, painful, red with a decreased range of movement. Occur, as we said, it's common. 80% involved joint are severely tender. Children below 5 years, arthritis usually mild, but unfortunately carditis more prominent. Arthritis don't progress to the chronic destructive arthritis like rheumatoid arthritis, but resolve to the normal after resolved acute infection. Return to the normal. Arthritis, really some point about, aspirin has been the traditional treatment, but nowadays other non-steroidal might be considered in view of race syndrome. If it is failed few doses to respond, consider an alternative diagnosis of rheumatoid. Very sensitive and a very magic response. Carditis is the second most common manifestation. As a pancreatitis, which means endocarditis, myocarditis, and pericarditis, occur in 40 to 50% of cases. Carditis is the only manifestation of rheumatic fever that leaves a sequelae and permanent damage to the heart. What I mean that the skin infection, chorea, or arthritis, it's not leave the sequelae of the acute rheumatic fever. But if the valve involvement, it might progress and damage the valve. Valvitis occur is common in acute phase. Chronic phase, in a chronic recurrent infection or chronically, there is a fibrosis, calcification, stenosis of valve disease or heart valve. Endocarditis lead to the valvular heart disease with a myocarditis fatal in about 1%, especially in children. Tachycardia in myocarditis beyond expected for temperature. There is disproportion, as we said in lecture of myocarditis. Cardiac enlargement, shortness of breath, a murmur of aortic incompetence is common in older children or young adults. Pericardial rub in 40 to 60%. The proportion or percentage, the commonest valve to be involved is a mitral valve, about 70% of patients. The second most common is aortic valve, 50%. The third valve to be involved, tricuspid valve. The very rare, the least involvement is the pulmonary valve. A suspected carditis, really, if a new or changed cardiac murmur. A soft systolic murmur, mitral regurgitation is very common. A soft mid-diastolic caricombs murmur is typical due to the valvitis, highly suggestive, with the nodules in mitral valve leaflet. Diastolic murmur at the base, suggestive aortic regurgitation, about 50% of acute rheumatic carditis. The third major criteria is Sydenham's chorea. St. Vastas dance occur in a 5 to 10% of cases, mainly in younger age, and mainly in the girls of 7 to 15 years age. may appear even 6 to 12 months after the acute attack of rheumatic fever. Clinical manifestation as clumsiness, deterioration of the handwriting, emotional lability, or grimacing of the face. Clinical sign like pronator sign and milk sign. Erythema marginatum, which is the least common. Nowadays, see, it's least common. Occur in 5%, less than 5%. Unique, transient, serpentinous, wavy margin looking lesions and macules or papules of 1-3 cm in diameter. Pale center with a red irregular margin, more on trunk limbs, not itchy. Never in the face involvement. Worsen with application of heat and fades when the application and when the patient is cold. Often associated with acute chronic carditis, while subcutaneous nodule will be associated with acute carditis. Subcutaneous nodule, well, this major criteria occur 10%, about 10%, 2 to 3 weeks after the onset of fever. Painless, pea-sized, palpable nodules, mainly over extensor surface of big joint like elbow or spine, scapule, even knuckles and the scalp, associated with the strong seropositivity, always associated with the severe carditis. Other what called minor fever up to 39 degrees centigrade in 90% of patients. Arthralgia, different from arthralgia, only pain, no limitation, no tenderness, only pain in the joint. While the arthritis, as we said, hot, tender, pain and limitation of movement. Pallor, anorexia, loss of weight, high ESR and sedimentation rate, anemia, leukocytosis, elevated C-reactive protein, SO titer more than 200 TOD unit, peak value attained within 3 weeks and then fade within 6 weeks and come down. DNSE B test positive. Throat culture for group A beta hemolytic, also it's a minor criteria. ECG change minor criteria. ECG prolonged PR interval, first degree, second or third degree, which is less common, ST segment or T-wave inversions. 2D echocardiography, really, this is not a minor criteria, this evidence. Valve edema, mitral regurgitation, left atrial, and this is evidence of the myocarditis. Left atrial dilatation, left ventricular dilatation, pericardial effusion, and decreased contractility. Diagnosis: rheumatic fever is mainly clinical diagnosis. No single diagnostic sign or a specific lab test available for diagnosis. Diagnose based on modified or revised Jones criteria, which is put it in 1954, until now revised several times. These criteria include major criteria, minor criterion, with a supportive evidence of group A streptococcal infection. Major criteria, as we said, carditis, polyarthritis, chorea, erythema margin, subcutaneous, while minor criteria is divided in a clinical lab, as we said previously, and supportive evidence, increased titer of antistrepto or other positive throat culture of a group A or recent standard scarlet fever. So the presence of 2 major criteria or 1 major criteria, 2 minor criteria indicate high probability of acute rheumatic fever if supported by evidence of streptococcal infection. There is some exception for these revised Jones criteria, like chorea, as we said, alone, if other neurological cause excluded, say it is most probably rheumatic chorea. Insidious or late onset carditis with no other explanation, we can say it is most probably this is rheumatic fever. Patient with documented rheumatic heart disease, prior rheumatic fever, 1 major criteria enough, or of fever, arthralgia, high C-reactive protein suggest a recurrence. Differential diagnosis: juvenile rheumatoid arthritis, septic arthritis, sickle cell arthropathy, Kawasaki disease, myocarditis, scarlet fever, and leukemia. Treatment: really 4 steps. Step 1, primary prevention, means eradication of streptococcal infection. Step 2, anti-inflammatory, as we said, aspirin and non-steroidal and even steroid. Streptococcal, step 3, supportive management and management of a complication, while step 4, secondary prevention of recurrence attack, because as we said, group A beta hemolytic streptococcal might recurrent attack of the patient. Primary prevention: eradication of streptococcal. The main agent in penicillin by single injection or oral penicillin for 10 days. If allergic, we use erythromycin for 10 days. While the supportive evidence, anti-inflammatory agent, aspirin, as we said, to start with 75 to 100 and divided doses for 6 weeks. Really, if the patient become better, reduce it to 50 or 75 and continue. If available, attain blood culture to adjust the dose. Otherwise, let it 75 to 50 after 2 weeks of the 75 to 100. Carditis, we use aspirin, addition prednisolone here, our role, 2 to 0.5 milligram per kg, given as a divided dose for 2 weeks. Then taper over 2 weeks. During tapering, added aspirin 75 milligram for 2 weeks and continue aspirin alone for the 4 weeks. While step 3, supportive management and management of complication, bed rest, especially in the myocarditis. Treatment of congestive cardiac failure by digitalis, diuretic, AC inhibitor. Treatment of chorea by diazepam or haloperidol. Rest to the joint and supportive splitting in acute arthritis. While the most important, secondary prevention of rheumatic fever. Prevent or recurrent attack, because when recurrent, especially if you have rheumatic valve disease, it will be more damage to the heart. So agent penicillin, benzathine penicillin G, intramuscular every month, divided doses, and divided site of injection, or oral penicillin or sulfa orally for a period, we will say it. And for individual allergies, use erythromycin. In the patient really high risk, we might make the interval of injection every 3 weeks. And the duration of secondary infection of rheumatic fever, there is a category: rheumatic fever without carditis, and the rheumatic fever with valvular heart disease and the echo finding clinic suggested, or rheumatic fever with carditis but no echo or clinical suggestion. So the first group, rheumatic fever with carditis and residual heart disease and persistent by clinical or echocardiography. This group, at least 10 years since the last episode, or at least until 40 years of life, and sometimes long life prophylaxis. Recurrent rheumatic fever with carditis but no residual heart disease clinically or echo, 10 years or well into the adulthood, whichever the longer the duration is from the first attack of acute rheumatic fever. While rheumatic fever without carditis is a 5 years or until the age of 21st years, whichever is longer. Prognosis: rheumatic fever, as we said, can recur. And the major criteria or the major manifestation it recover completely, except is the rheumatic carditis and valvular disease. So individual experience in new group A case of the recurrent streptococcal infection, if not on prophylactic medications or antibiotic. Good prognosis for older age group, and if no carditis during initial attack. Bad prognosis for younger children and those with a carditis with valvular lesion. We will provide you 3 scenarios of acute rheumatic fever, different presentation. Please do reporting and write to us back for your report. First case is arthritis without cardiac involvement. This is the first scenario. Second scenario is the chorea without arthritis or carditis. Do reporting and send it back to us. And the third case is carditis with or without carditis. Please the report it with the main line. Diagnosis, we give you a diagnosis. How to confirm diagnosis, differential diagnosis, and management and prognosis. This is the Ashoff nodules, and this is under lower power microscope, myocarditis, and a case of carditis with the pulmonary congestions, and after giving treatment, the X-ray is more clear, and subcutaneous nodule, and this is erythema marginatum. See you soon. Thank you for participation.